مش خلاص لايف. يلا بقى انت عندك ماشي الحياة. حاتم جه؟ هات لي الكاميرا اللي معاك بسرعة.
Good afternoon, everyone. I'd like to welcome you all. I think mostly we are from the phoniatric department, from the physical medicine, and from the neurology department, right? Somebody outside these domains? I'm from geriatric department, so welcome to you all. We have to all through in English language because we have Dr. Linda Worrell. She doesn't understand Arabic so far, but by the end of her visit, I think she will be able to understand Arabic very well. First, let me welcome Professor Linda Worrell. She came a long distance from Australia, and I'm very thankful for her accepting our invitation. Her presence will add a lot of knowledge to our information about speech therapy. Professor Linda is chairperson in Australia Aphasia Association. She authored about 6 books, 15 book chapters, and more than 200 articles in this domain. So thank you so much for coming. I'd like to welcome also our guest, Professor Najwa Nassar, head of the Physical Medicine and Rheumatology Department, and Professor Nahla Al-Fai, head of the Phoniatric Department. I think their presence will add a lot to our discussion, and it will enrich the discussion in this session. Now we start with Professor Linda. She'll talk about 3 key clinical indicators of effective stroke care for people with aphasia. After that, I'll talk about early management of stroke cases. Unfortunately, the next speaker, Dr. Mohammed Al-Gibali, didn't show and didn't apologize, so I'll have with you some case presentations about how to manage neurological patients instead of him. After that, we have Dr. Ahmed Al-Bokri will talk about indications for patient referral for magnetic stimulation. Dr. Tamer Roshdi will talk about cognitive rehabilitation, and Dr. Tamer Hussein will talk about rehabilitation of the glottal or dysphagia. And by the end, we will have case presentation with Professor Linda Worrell. Now I invite Professor Linda to start the presentation.
Thank you very much, Lynn. Thank you for the invitation to fly all the way from Australia, but to see the pyramids has been amazing, absolutely amazing. The title of my presentation is 3 clinical indicators of effective stroke care for people with aphasia. I'm aware that we don't have a room full of phoniatrists or speech therapists, so I'm talking about stroke care as a whole today. I'm particularly talking about stroke care for people with aphasia and talking about 3 clinical indicators that can improve the quality of care not only for people with aphasia but also for stroke care generally. So may I ask the question straight up. Are all staff in your hospital trained in supported communication techniques for patients with aphasia? Yes or no? Yes? No? No? Yes? No. Thank you. Are all patients with aphasia offered aphasia rehabilitation? No. Are all patients with aphasia given the opportunity to provide feedback about their stroke care? No. So I understand that we are not the same. Egypt is in Africa. Australia is a continent all of its own, but we have commonalities. We have a big desert, like Egypt. We have a big rock, Uluru, which is in the middle of Australia. And the art at Uluru is 5,000 years old. The same time as I saw in Memphis yesterday. So we have ancient civilization as well, but our health systems, I understand, are very different. But I thought you still might be interested in how we do things in Australia. So, first of all, why focus on aphasia? Aphasia occurs in about 37% of stroke survivors. So it's a not insignificant proportion of people with stroke. Compared to non-aphasic stroke patients, patients with aphasia have poorer outcomes, highest costs in their stroke care, inadequate hospital and community rehabilitation, and they have some of the most difficulty participating in community life. So in many respects, they are, do you understand the term cellar dwellers? If you follow football, the team at the bottom of the league table are the worst. So people with aphasia have the worst outcomes. So it therefore goes that if we improve outcomes for people with aphasia, we improve outcomes for stroke care across the board. So what are clinical indicators? Indicators provide a quantitative basis for clinicians, organisations and planners aiming to achieve improvement in care and the processes by which patient care is provided. Now this person, Main, says monitoring healthcare quality is impossible without the use of clinical indicators. They create the basis for the quality improvement and prioritisation in the healthcare system. To ensure that reliable and valid clinical indicators are used, they must be designed, defined and implemented with scientific rigour. Do you have clinical indicators in rehabilitation in Egypt? Yes? Yes, you do. How many are for aphasia? 0? Yes. It's about the same in Australia. So we are also developing clinical indicators to improve the care for people with aphasia. So my aim today is to distill about 40 years of aphasia research, teaching and practice into just 3 clinical indicators of effective stroke care for people with aphasia. This is my career, beginning in Melbourne as a clinician, moving to do my PhD at the University of Nottingham in the Stroke Research Unit at the University of Nottingham, which was one of the first stroke units in the UK. And then I moved to the University of Queensland in Australia and I have become recently the chairperson of the Australian Aphasia Association. So what I have done for this presentation is I have looked at 35 of our studies that report the experiences of stroke care by people with aphasia and their families. So this is people with aphasia and their families telling us about their stroke care and telling us about adverse events and dissatisfaction with care. So I grouped those issues into 3 areas. And then I've looked at the literature on evidence-based practices that can improve these areas of practice. Okay? So these 3 clinical indicators have emerged from 35 studies of patients' experiences of stroke care in Australia. These were the 3 themes: poor staff communication skills, lack of information, support and therapy, and thirdly, that their voices were not heard. Now, these are often considered to be the soft areas of rehabilitation. Not technical, but soft areas. Would you use that term? The thing is that we do not do these very well at all, and that we are not doing a very good job of these because we think they're easy to do, but they're not. The first clinical indicator is that all staff can communicate effectively with patients with aphasia. Our research has said that the problem is many staff avoid talking with patients with aphasia or do not adjust their communication to accommodate for the affected language abilities of the patient.